Signs and symptoms of lung cancer. Mohammed Staouni, MD, FCCP. Consultant. Pulmonologist and intensivist. Department of Medicine. King Faisal Specialist Hospital. Lung cancer. Epidemiology. Lung cancer is the most common cancer worldwide, accounting for 1.3 million deaths annually. Lung cancer is the leading cause of cancer-related death. It is the most preventable form of cancer. There are two major types of lung cancer. 1. Non-small cell lung cancer, 87%. 2. Small cell lung cancer, 13%. Lung cancer survival. Lung cancer 5-year survival rates average 16%. Over half of people with lung cancer die within 1 year of being diagnosed. Survival for non-small cell lung cancer NSCLC is directly related to stage at time of diagnosis. 5-year survival ranges from 60% for stage I disease to 5% for stage 4 disease. Even for early lung cancers, stage I, there is a relationship between tumor size and survival. Early diagnosis increases overall cure rate and allows more limited surgical resection to achieve cure. Lung cancer symptoms. Lungs have few specialized nerves, pain receptors. Symptoms are frequently absent until locally advanced or metastatic disease is present. Symptoms vary depending on the type and location and size of the tumor. The majority, 75% of patients with lung cancer have advanced local or metastatic disease at presentation. Many symptoms are similar to those of other common illnesses. Lung cancer symptoms. Symptoms result from local effects of the tumor, regional or distant spread, distant effects not related to metastasis, paraneoplastic syndromes. Approximately 3/4 of patients have one or more symptoms at the time of diagnosis. Lung cancer symptoms. Intrathoracic, local, disease. Restricted to the area where the cancer started with no signs of spread. Cough, most common. Blood in sputum, hemoptysis. Shortness of breath, dyspnea. Wheezing. Chest pain. Pneumonia. 50 to 75% of patients at presentation. Most frequently in squamous and small cell carcinomas. Central tumors. New onset, or change in character, of cough in a smoker or former smoker should raise suspicion that lung cancer could be present. Bronchuria may be a feature of what is previously known as advanced bronchoalveolar cell carcinoma. If you have a persistent cough that lasts for over 3 weeks, see your GP. Intrathoracic, local, disease. Cough. Intrathoracic, local, disease. Hemoptysis. 25 to 30% of patients with lung cancer. Bronchitis is the most common cause. Likelihood of lung cancer 3–34% depending upon age and smoking history. Hemoptysis in a smoker with normal chest radiograph, 5% lung cancer on bronchoscopy. 20% of patients upon presentation. Dull, aching, persistent pain from mediastinal, pleural, or chest wall extension. Typically present on the same side of the chest as the primary tumor. Presence of pain does not necessarily preclude resectability. Obstructive pneumonitis or a pulmonary embolus related to a hypercoagulable state may be the cause of chest pain. Intrathoracic, local, disease. Chest pain. 25% on presentation due to airway obstruction, extrinsic or intraluminal. Obstructive pneumonitis or atelectasis. Lymphangitic tumor spread. tumor or bland emboli. Pneumothorax. Localized wheeze, partial obstruction of a bronchus. Regionally advanced disease. Cancer has directly spread from where it started to nearby tissue or lymph nodes. Hoarseness, tumors involving recurrent laryngeal nerve, causing unilateral vocal cord. Paresis, LR, with hoarseness and a bovine cough. Can be from laryngeal cancer. Stridor, high-pitched sound, usually heard while taking a breath. Intrinsic or interluminal narrowing of upper airways. Hemodiaphragmatic paralysis, bronchial carcinoma can directly invade the phrenic nerve, causing ipsilateral paralysis of the hemodiaphragm. Dysphagia, difficulty or pain in swallowing from involvement of the esophagus by tumor or mediastinal lymph nodes. Pleural or pericardial effusion with tamponade. And malignant dysrhythmias. Regionally advanced disease. Regionally advanced disease. Pancreas tumor. Tumor in the apex, the superior sulcus, of the lung can erode the ribs and involve the lower part of the brachial plexus, C8. T1 and T2, causing severe pain in the shoulder and down the inner surface of the arm and atrophy of hand muscles. NSCLC, typically squamous cell. Rarely SCLC. The sympathetic ganglion can also be involved, producing Horner's syndrome. Ptosis. Inophthalmos. Meiosis. Anhidrosis. Regionally advanced disease. Superior vena cava syndrome. Obstruction of blood flow in the superior vena cava. Results in signs and symptoms of superior vena cava. SVC syndrome. SVC obstruction causes shortness of breath, early morning headache, facial congestion and edema. Involving the upper limbs, the jugular and chest veins are distended. The chest radiograph shows widening of the mediastinum or a right hilar mass. SCLC is the most common cause. Distant metastasis. Brain. Symptoms are similar to those with other tumors. Headaches. Vomiting. Nausea. Seizures. Weakness. Confusion. Visual disturbances. SCLC, 20 to 30% of patients at presentation. Role for prophylactic cranial irradiation. NSCLC, adenocarcinoma and least with squamous cell carcinoma. Larger tumor size and the presence of node involvement. Bone. Common. Bone pain and pathological fractures. Liver. Uncommon 3%, early. Detected by liver enzyme. Abnormalities, CT or PET. Abdominal pain, right side. Yellowing of the skin and eyes, jaundice. Fatigue. Weight loss. Nausea. Distant metastasis. Very frequent, 40%, postmortem. Often asymptomatic. Not all adrenal masses detected on staging scans represent metastasis. Benign lesions, adenomas. Nodular hyperplasia, hemorrhagic cysts, are common. PET may be particularly useful in distinguishing a benign from malignant adrenal mass. MRI consistent with a benign adenoma or a negative needle biopsy can exclude metastasis. Paraneoplastic syndromes. Paraneoplastic syndromes are remote effects of tumors that are not related to the direct invasion, obstruction, or metastasis. Paraneoplastic syndromes. Hypercalcemia. Symptoms of hypercalcemia include anorexia, nausea, vomiting, constipation, lethargy, polyuria, polydipsia, and dehydration. Confusion, coma, renal failure and nephrocalcinosis are late manifestations. Incidence 6% squamous cell carcinoma. Adenocarcinoma. Poor prognostic factor usually in advanced disease. Stage 3 or 4. Median survival of few months only. Paraneoplastic syndromes. Hypercalcemia. Bony metastasis and less commonly secretion of a parathyroid hormone-related protein. PTHrP, calcitriol or osteoclast activating factor. Treatment with hydration and bisphosphonate. For symptomatic patients who have serum calcium of 12 mg/dl, 3 mmol/L, or higher. Paraneoplastic syndromes. Hyponatremia. 10% of patients with SCLC exhibit SIAD. SCLC accounts for approximately 75% of all malignancy-related of SIAD. Symptoms include anorexia, nausea, and vomiting. Cerebral edema when onset of hyponatremia is rapid. Irritability, restlessness, personality changes. Confusion, coma, seizures, and respiratory arrest. Hyponatremia resolves within weeks of starting chemotherapy. Paraneoplastic syndromes. Hyponatremia. Ectopic production of adrenal corticotropin, ACTH. Common in SCLC, worse prognosis, and in carcinoid tumors of the lung. Muscle weakness, weight loss, hypertension, hirsutism, and osteoporosis. Hypoglycemic alkalosis and hyperglycemia are usually present. Paraneoplastic syndromes. Cushing's syndrome. Lung cancer, typically SCLC, most common cancer associated with immune-mediated paraneoplastic neurologic syndromes. Lambert-Eaton myasthenic syndrome, LEMS. Precede the diagnosis of SCLC 80% of cases by month years. Cerebellar ataxia. Sensory neuropathy. Limbic encephalitis. Encephalomyelitis. Autonomic neuropathy. Retinopathy. Ophthalmoclonus. A CT chest or PET is indicated in current or former smokers who have a suspected paraneoplastic neurologic syndrome. Paraneoplastic syndromes. Neuromuscular manifestations. Dermatomyositis and polymyositis, two distinct forms of inflammatory myopathy, both of which are manifested clinically by muscle weakness. Can be the presenting symptom in patients with lung cancer or can develop after diagnosis. Paraneoplastic syndromes. Hypertrophic pulmonary osteoarthropathy PA. 3% of all bronchial carcinomas, particularly squamous cell carcinomas and adenocarcinomas. Symptoms: joint stiffness and severe pain in the wrists, ankles, knees and elbows with clubbing of the fingers. X-rays show a characteristic proliferative periostitis at the distal ends of long bones. Isotope bone scan or PET, diffuse uptake by the long bones. It may regress after resection of the lung tumor. Paraneoplastic syndromes. Hematologic manifestations. Anemia is frequent in patients with lung cancer and can contribute to fatigue and dyspnea. Leukocytosis/thrombocytosis, 15% NSCLC bad prognosis. Eosinophilia, rare. Hypercoagulable disorders include Trousseau's syndrome, migratory superficial thrombophlebitis, DVT/P, DIC, thrombotic and non-thrombotic microangiopathy. Paraneoplastic syndromes. Hematologic manifestations. Lack of appetite. Weight loss. Weakness. Feeling tired all the time. Paraneoplastic syndromes. Cancer cachexia or wasting syndrome. Lung cancer. Conclusion. Early detection based on symptoms is difficult in lung cancer. Symptoms often do not appear until the disease has spread. When lung cancer is diagnosed early, it is a result of screening or testing for unrelated conditions. Chest X-ray and CT scan should be done if lung cancer is suspected. The clinical manifestations of lung cancer can be due to intrathoracic local effects of the tumor, cough, hemoptysis, dyspnea, intrathoracic regional effects, hoarseness, stridor, extrathoracic metastasis, bone, brain, liver, paraneoplastic phenomena, hypercalcemia, hyponatremia, Cushing's syndrome, hypercoagulability disorders, and various neurologic syndromes.